Okay, wonderful. So let's have a quick look. So this meeting is primarily focused on those in training, and it's wonderful to see that the vast majority of people that are here are trainees, but obviously the specialists are a really important part of our meeting to give insight and to give some commentary and feedback, as we are also trying to prepare everyone who are writing exams for their exams. So wonderful. I see UKZN is actually, at the moment at least, from those who've answered, the best represented, 10 out of 37. Second, Wits, then Pretoria, and then Cape Town. So fantastic, lovely spread there. We've got people from everywhere. I see we've got one from the Free State, but I think they sometimes share the same computer, so maybe there's more than one person there. So then Gauteng, KZN, Western Cape, and not in South Africa, not yet. We are expecting somebody to join us from the Emirates today. So he will probably join us later. Lovely. Good. So let me just quickly show that for those who just can see. Yep, KZN leads the pack today. And Gauteng as well, and then KZN. Fantastic. So first from my side, just a big welcome to everybody. We've got people here literally from all around the country, which is wonderful. For those who are new, I'd like to just ask you to, in the chat box, just say, if this is the first time you're attending our meeting, just say where you're from and what you do. That would be wonderful. And the purpose of this meeting is to really help everybody in the country to start thinking and working together, at least at an educational level. And it was started, this meeting, by the fellows at the University of Cape Town, but they felt, and we all felt, that this would be wonderful if we could expand it to everyone. And it's been a huge success, and we're very excited about the amazing inputs we've received from our teams across the country. Today, I am particularly happy to introduce the team from the University of Pretoria under the guidance of Dr. Jan Gert Nel, who I worked with in the University of the Free State when Jan was still a registrar. In the meantime, he's done all kinds of things. He's now a consultant with a PhD. So wonderful, Jan Gert, to have you here today. And I'm going to ask Jan Gert to introduce the speakers and also to lead the conversation during the Q&A time. And as we go along, we'll obviously give everybody the opportunity to comment or to ask questions. So it's Jan Gert's first time. Wonderful to have him here. I think it's also his first time at our meeting, if I'm not mistaken. So really great to have you. Jan Gert, over to you.
Hi, good afternoon, Prof. Flo, and thank you for the opportunity to be part of this forum. I do agree with you that it is actually a high time that we all get to sit around a table and discuss issues that involve us all, actually. Today's topic was about the overarching topic for today is about implementing patient blood management in our country. And as the first person who's speaking today is Dr. Debbie Vaz. She is a senior pathologist in our institution. She's going to speak about perioperative anemia and the management thereof as part of patient blood management. And then after that, we will have Dr. Sarita Singh speaking on the hazards of perioperative and intraoperative transfusion. And I will finish it up with a little talk about a topic that I was not really familiar with prior to preparing for this speech, about the utility of clinical decision support systems in improving blood usage during patient blood management. I will allude to that, and I'll also maybe say a few words of patient blood management, seeing as that it is a really topical entity, especially in the space that we function in, whereas which can be considered a resource-constrained country and a resource-constrained setting, and I will end up with that. And obviously, after every one of the speakers has spoken, I will give opportunity for questions and answers via the chat box. I will monitor the chat box and we can have a good conversation. First up, Debbie.
Thank you, Jan. Good afternoon, everyone. Can everybody see my screen, or just Jan,
Yes,
tell me if you can see it?
We can. Thank you, Debbie.
Okay, thank you, Prof. All right, so my topic today was handling of perioperative anemia. And I thought before I start, I just wanted to let you know a little bit about myself, since we're not able to do networking anymore for the time being. And I would love to hear about my colleagues as well when they speak, if they'd like to share a little bit about themselves. So just background, I did complete in 2008 my MBBCH, and after internship in ComServe, I did emergency medicine for about 6 years. I worked at a private hospital at that stage, and I also did surgical assisting with general surgery, obs and gynae, as well as orthopedic. So I had my fair share of defibbing and resussing, and I also was involved with blood product transfusion, both in the emergency setting, and I got to see firsthand, perioperatively or operatively, transfusion handling products. So just to start off with, patient blood management is very new. It wasn't being practiced at that time. And obviously with emergency blood products transfusion, it's a different kind of transfusion setting where we don't really have time for PBMs. So it is more, blood on the floor, you need to transfuse now. So it's a different kind of transfusion setting. So today we'll be talking about the perioperative, meaning the elective surgical cases. Okay, so like I said, a little bit about patient blood management. It was first, the concept was thought of firstly with the Society for Blood Management, or SABM. This group was formed in 2001, and then in 2018 they came out with these guidelines on choosing wisely. And this was really just 5 things that physicians and patients should question. And that this is where, perioperative anemia came into play. So it says that in point 1 that you shouldn't proceed with elective surgery in patients with properly diagnosed and correctable anemia until the anemia has been appropriately treated. So my talk will be focused really on point 1, but just to discuss patient blood management, what the definition is. It's said to be the timely application of evidence-based medical and surgical concepts designed to maintain hemoglobin concentration, optimize hemostasis, and minimize blood loss in an effort to improve patient outcome. That patients' own blood is seen as a resource that should be conserved and managed appropriately as a standard of care. And recently in 2018, 2019, there was a development of, at the consensus conference in Frankfurt, where research-based recommendations for PBM practice were published in a guideline format. So this is just really a little bit of a background on PBM. So moving on to perioperative handling of anemia. As I said before, we're going to discuss mostly elective because, as you can see, this is just a graph taken from a study where elective surgery is where the biggest impact of PBM is obviously going to play a role. And that emergency setting, like I said, it's a different kettle of fish. You transfusing in an emergency setting, you don't have time for PBM. All right, so anemia, what is anemia? So what is the definition of anemia in a perioperative setting? WHO defines anemia, males being less than 13 grams per deciliter, females less than 12 grams per deciliter, and pregnant females less than 11. In a perioperative setting, anemia target for all is actually suggested at 13. Reason for this is that anything less than 13 was thought to put female patients at risk. Just also, why do we use hemoglobin as a target or for anemia or target to reach is because it is the oxygen delivery or oxygen capacity that we get from the formula. Oxygen delivery equals hemoglobin times cardiac output. So this is where hemoglobin plays a part in a function of oxygen delivery. And hemoglobin is therefore what we use as a surrogate of active red cells in the circulation because there is no real test to test for active red cells in the circulation. So why is perioperative anemia management important? It's proven that perioperative anemia is an independent risk factor for morbidity and mortality. It leads to slow recovery in patients as well as prolonged hospital stay. Historically, allogeneic blood transfusions were used to treat anemia. So that's something that it's still being seen. It was not too long ago that a patient was going into surgery, or one of the surgeries I was assisting in, and they were anemic, and blood was ordered to treat the anemia. So it's still something that's being done today, and yeah, so it's something that people are not familiar yet with the PBM kind of management process. Also, costs involved with transfusion, as well as shortage of blood products, should be bear in mind why perioperative anemia is important. Risks also associated with allogeneic blood transfusions. So we should remember that receiving an allogeneic blood transfusion is not without risks, and that in itself, intraoperative blood transfusion is associated with risks. So my colleague Sarita will discuss more of this, but things like immunomodulation, post-operative infection, thromboembolic complications, and recurrence of cancer. So there was a study, a meta-analysis study, showing that 42%, so they took about 12,000 patients, and 42% had an increased recurrence of colorectal cancer who received a transfusion. So I just thought that was also quite interesting. The next slide, I've just taken this from a Blood article where anemia management was split up into 3 groups, where the management was done preoperatively, intraoperatively, and then postoperatively. Preoperatively, you should diagnose obviously the cause of the anemia, correct the anemia, optimize and maintain hemoglobin levels, and identify any potential hemostatic problems. Intraoperatively, minimizing blood loss through various surgical techniques, blood conservation methods, viscoelastic point of care testing to select blood product use and optimize hemostasis, and then such things as tranexamic acid to decrease fibrinolysis. And post-operatively, the impact on anemia management is monitoring for obviously any ongoing blood loss, things like a surgical drain put in after or during the procedure to manage or to monitor the ongoing blood loss, and then limiting of diagnostic blood drawing or iatrogenic anemia. So I'll be discussing a little bit of each separately. In the Anesthesia and Analgesia Organization, they discuss perioperative anemia or patient blood management in 3 pillars. They say there's optimization of red cell mass, there's reduction of blood loss, and there's optimization of patients' physiological tolerance towards the anemia. So things like increasing the inspired fraction of oxygen or vasopressors will play a part here in this pillar. So this is similar to what they mentioned in the blood journal, but the 3rd pillar obviously just discusses the physiological tolerance towards the anemia. So this is just a flow chart from also a blood journal describing the process that should be followed in a patient that is going for surgery. So firstly, to screen for the anemia should be, they say, around 4 weeks before the surgery, although anywhere between, even before that is obviously better. But even if it is less than 4 weeks, it's better than no monitoring at all or no screening at all. Obviously, is the anemia reversible or irreversible? So, for example, somebody with hemoglobinopathy or MDS will be a little bit more difficult to reverse, whereas someone who has iron deficiency could be corrected. The hemoglobin, if it is less than 13, you evaluate the iron status. So you can do this either through transferrin saturation level, or you can do it through, they say is more accurate, the reticulocyte hemoglobin concentration. So this technique is more reliable when a patient, for example, has an inflammatory state or an infective state. If the patient is iron deficient, you can initiate iron therapy, either oral or IV. They suggest IV if there's an intolerance to oral iron or gastrointestinal uptake problems. And then also consider referring to a gastroenterologist to rule out malignancy. So this is your male patients who have a low hemoglobin, or obviously postmenopausal females, so in investigating for any sort of GIT bleed. If the patient obviously does not have a hemoglobin that's less than 13, there's no immediate action that's required, that they just need to remain anemia vigilant and monitor for new onset anemia in high-risk populations. And then implementation of PBM and anemia preventative measures. If the hemoglobin is normal, or the reticulocyte hemoglobin concentration or saturations are normal, you check for serum creatinine or GFR. If that's abnormal, consider obviously kidney disease. If it is normal, do a B12 and folic acid level. If it's low, you can replace that. And if it is normal, then obviously consider that is anemia of inflammation, and you could possibly do erythropoietin stimulating agents at this point. But obviously all these tests are really run in unison, so it's not one done after the other. But there's things to consider in each step. Oral iron versus intravenous iron. The oral iron obviously is more cost effective, but IV iron can be more expensive, but it is cheaper than giving a blood transfusion. Oral iron is easier to take, whereas IV iron is more cumbersome to administer. There's GIT side effects associated with oral iron, and with IV there's hypersensitivity reactions, but there is it's less frequently seen these days with the newer agents of IV iron. The oral iron, sometimes there's decreased absorbance during inflammatory states due to an increase in hepcidin. The IV iron is better absorbed. It's taken up by the macrophages, which increases the intracellular iron, and this actually causes an increase in ferroportin. And so this actually counterbalances the decreased ferroportin caused, or the breakdown of ferroportin caused by the increased hepcidin. The oral iron has a slower mode of action. There's a high dose increase in hepcidin if you give it in alternate days, but with IV iron, there's a rapid response. These are just some of the formulations for IV iron that we use, or that's used. We, in our setting, use mostly iron sucrose, or we know it as Venofer. But the rest of them, you can see the table. It is from blood. It's just a little bit blurry here on my side. But the table I did get from this blood article there. Erythropoiesis stimulating agents. So these are not routinely recommended, but there's increasing support for its use. If it's used, it needs to be given to patients which are anemic, but a nutritional screen has been corrected or is normal. It can cause a functional iron deficiency in inflammatory states. So therefore, they usually give it together with iron. And also, there's no consensus on an optimal dose, duration, or routes of administration. The associated risks with ESA is ischemia and thrombosis, and this must obviously be balanced with the benefit the patient can get from an erythropoietin stimulating agent. So in 32 trials, in one of the studies showed from 4,700 patients that actually ESA decreased the risk of transfusion, and there was no associated thrombosis risk. And they speculate that the reason is that they give the ESAs for short periods of time, and therefore the thrombosis risk isn't as high in someone who's getting erythropoietin for longer periods of time. And then obviously there's the worry that ESA use in cancer patients can actually lead to tumor progression due to the tropic effect on the cells. So they suspect, or they studied, that the EPO can bind to the Ephrin B4 receptor on the tumor, and this may cause or induce angiogenesis. This is also just a flow chart on what treatment to take, or what steps to take, depending on whether the ferritin is low or if the ferritin is high. And if the saturation is low, it would be your typical absolute iron deficiency anemia, where oral or IV iron is indicated. Or for example, if it is ferritin is more on the high level, but the saturation is low, then it would be your functional iron deficiency anemia. And IV iron would possibly be more useful at this point. So all the green blocks are where IV iron would be beneficial. The orange is where iron trial may be beneficial. And the red is where there is iron overload and iron is not indicated. Hemostasis optimization, so things that need to be assessed before patient goes into theatre. The risk assessment, patient history, coagulopathy, any sort of drugs the patient is taking, anticoagulants or antiplatelets, quantitative as well as qualitative coagulation assessment tests. So things like your viscoelastic point of care testing, which assesses your dynamic clot assessment. Your qualitative coagulation assessment would be things like your platelet function assays, and quantitative would be your PTTs, your PT, INR. So all of this they just recommend would be important, but neither one will, tell you specifically how the patient is going to react in theatre. It's really just to give you an overall indication if you suspect that the patient might be or have a bleeding phenotype. Also there's the use of this as well is for goal-directed therapy to correct certain abnormalities. So if you need to give plasma or procoagulants, you can see at what area the patient is lacking. You can also, there's adjustment of anticoagulants before the procedures, so whether you're going to stop them or decrease them. And then systemic and topical hemostatic agents can be used as well. Minimizing surgical blood loss. So they recommend obviously laparoscopic surgery where possible, with anesthesia, neuraxial anesthesia, which gives a sympathetic blockade, and it causes decreased venous tone as well as blood pressure, helps with decreased blood loss. Certain surgical techniques like cauterization or special cauterization devices, I'm not sure if we have that available here, but there's certain devices now that they say can basically cut through like the liver without causing any sort of blood loss. So basically like sealing as it goes. Patient position is important. So where the venous return is not obstructed, I think it's slightly lifting the left-hand side so that the inferior vena cava isn't compressed while lying down. Fibrinolytic inhibitors such as tranexamic acid or epsilon aminocryptoric acid. Things like fibrin sealants, so this will help in the surgery to decrease the bleed. And then there's cell salvage techniques. So when the blood loss is predicted to be over 1,000 mils, cell salvage is where they take the patient's own red cells, they wash them, filter, and then resuspend it in saline. So the patient basically will get back their own red cells but suspended in saline, which means they won't get any plasma in that or platelets. The concern over that would be obviously if it can cause a coagulation, a dilution in the coagulation factors, and also possibly malignant cell reinfusion in patients that obviously are that have cancer. With acute normovolemic hemodilution, what they do there is that the patient's red cells are basically patient's whole blood is removed and they reinfuse 50% colloid solution and 50% crystalloid solution. So what this does is it decreases the red cell loss during surgery. So when there's surgical blood loss, it's more dilute kind of blood that gets lost. And then the whole blood, this is the benefit of it, that it's whole blood that's actually being reinfused back into the patient. And obviously these techniques are safer because it's not allogeneic, it's the patient's own red cells and products that are being reinfused. And then there's preoperative autologous blood donation. What this is basically patients donate their own blood before the procedure, and then they get that blood given back to them during the course of the surgery or after the surgery. The problem with this is there's still, it's still prone to clerical errors in obviously the blood product. You could get somebody else's blood product if it's not correctly identified or labeled. You can also get problems due to the storage of the blood or the product. And then obviously that still leads to risks or transfusion risks. And the other thing is the risk of anemia, which is resistant to recovery. So the patients can actually become too anemic before the procedures, and that puts them at risk. And then my last slide is just on discussing where this all really came from. And there's something called the bloodless medicine programs. And this is quite popular in the US. And really it stemmed from treatment of Jehovah's Witness or religious Jehovah's Witness patients, which did not want any sort of blood transfusion. And because doctors had to come up with solutions on how to optimize this patient's hemoglobin levels, from that, it stemmed that, programs for, optimizing someone's hemoglobin and decreasing the need for transfusion was a possibility, and not just in Jehovah's Witness patients, but in any patients. And this is where restrictive transfusion practices were thought to be just as good as liberal ones, or if not better. Patients were having less side effects or less risks, and they weren't doing worse. They were actually, the outcomes were the same. And yeah, so all of this, just wanted to discuss my references. These are my references, and I got a lot from Blood Bank Guy. I don't know if you've heard of him or his podcasts, but I do recommend his podcasts. He not only does like teaching videos on transfusion practices or basics of transfusion medicine, but also podcasts with different doctors on important blood transfusion issues. So it's a really, really nice website, and I've put it there, and specifically on perioperative management of perioperative anemia, patient blood management, episode 52. So it's just what I would recommend anybody studying or learning for blood transfusion. Thank you.
Thanks very much, Deborah. That was wonderful to listen to you. Jan Gert, I'm going to hand over to you to manage the Q&A session.
Currently, I have one question on the chat box. It is from Hugo Bakker, who asked, any opinions on the PREVENT trial findings?
I don't know about the PREVENT trial findings, so I can't answer that question, but maybe somebody else if they know that. I'm not aware.
Okay, so I'm just going to say a few words. Thank you for the question, Hugo. So the PREVENT trial is a trial where it was basically for the use of preoperative intravenous iron to treat anemia in major abdominal surgery. And it was published quite recently in one of the Lancet journals. Actually, it was in the Lancet itself. And it has created quite a bit of controversy because with this particular trial, they were not able to show that IV iron was superior to placebo to reduce the need for blood transfusion. Now, that said, this trial has created some major controversy, and I happened to speak to Prof. Axel Hoffman on Sunday. We spoke on the telephone. He's one of the grandfathers of patient blood management, and he plus actually a group of the leaders in patient blood management has written a major rebuttal on that article to point out the concerns and issues. And I don't want to run ahead and talk about that before it's been published, but I know that it's already been accepted by the editors of the journal for publication. So as soon as it becomes available, I will share it on the South African Patient Blood Management Group if Axel doesn't do it before me. So watch that space, and you'll see that in the chat box, I've also just mentioned our South African Patient Blood Management Group and the WhatsApp group specifically, where we share new articles, events, new news on PBM. And if you want to join, you can just send me a WhatsApp and I'll add your details. Just send your name as well. Okay.
Hey, thank you. Our next question is from Rita Gavender. Thank you, Doctor. The question was, hi, may I offer the following comment regarding the pre-op autologous donation? The number of units depend on the baseline hemoglobin and shelf life of product require Example, red cell concentrates 42 days, whole blood is 28 days. Sorry, she just said, sorry, whole blood is 28 days. So that was rather a comment than a question. Thank you, Rita.
Jan Gert, if I can just make 2 quick comments.
Yes.
Just about hypersensitivity reactions first. So as Deborah has pointed out, hypersensitivity reactions are rare. And a lot of the concerns about IV iron comes from historical data when high molecular weight dextran ions have been used in the past. With the modern IV ions, and with those I mean the ones with which you can give a total dose infusion, currently in South Africa that would be Cosmofer, Monofer, and Ferinject, the rate of hypersensitivity reactions, true hypersensitivity, in other words, anaphylactic type reactions, is estimated to be between 1 in 10,000 to 1 in 200,000, so very, very rare. So these are very safe. And there's actually a study comparing safety of IV iron head-to-head with oral iron, and IV iron is about 3 times less side effects than oral iron. There is a reaction that is not dangerous that can sometimes occur during an infusion, especially if you dilute, interestingly enough, if you dilute the iron too much. So you must carefully follow the instructions on the package insert and not mix the ions in a liter of saline when it's supposed to go in 200 mils of saline. That often leads to more problems. People think they are making it safer. They're actually making it worse. Yeah, I think I'm going to leave it at that just for time's sake, because we still have 2 talks, I think. So we can maybe make more comments later if there's an opportunity. And I also want to welcome quite a number of people here from our PBM team. Dr. Matthew Gibbs and Ed Turton and Dr. Ian Lander. It's lovely to see all of you here. There may be more that I haven't seen yet in the participant column. So I look forward to your comments as well. Thanks.
Sure. The group of people I know just grows. Thank you very much, Prof. Low. I would now give Dr. Sarita Singh an opportunity to give us her presentation. Thank you, Sarita.
Good afternoon, everyone. I'm Dr. Sarita Singh. Just a bit about myself. I did some MO time in pediatrics, and I have a diploma in child health. I then left and I did MO time in clinical hematology in King Edward Hospital under Dr. Rapiti, and I very much enjoyed working with hematology patients. So now I am a hematopathology registrar at the University of Pretoria, and I feel very fortunate that I can progress in my career in hematology. I'm presenting the risks of perioperative blood transfusions today. Sorry, I'm just changing my screen. So when I looked at the topic, I approached it in 2 ways. The one is that in terms of surgical patients, this can be divided into 2 groups of patients, cardiac patients and non-cardiac surgical patients. The cardiac surgical patients, although they represent a limited fraction of the overall surgery done in hospitals, they take up 20% of annual blood transfusions administered in the United States of America. Patients undergoing coronary artery bypass grafts, 60% of those patients are transfused with blood. So I'm going to discuss blood transfusion in cardiac surgical patients and non-cardiac surgical patients. And then the other way in which I looked at the topic was that we're all familiar with the traditional complications associated with blood transfusions that you can get in any patient. So I went a bit into those complications, the ones that are seen more commonly in the perioperative period. And then there's another distinct entity that's been coming up in the literature, that a blood transfusion have significant impact on surgical outcomes. So the complications of blood transfusions can be divided into the acute transfusion reactions and the delayed non-infectious complications. With the acute transfusion reactions, they include the transfusion-related acute lung injury, transfusion-associated circulatory overload, sepsis, and allergic and anaphylactic reactions. The delayed non-infectious complications, we have the non-ABO hemolytic transfusion reactions, graft versus host disease, post-transfusion purpura, and then this entity of increased mortality in surgical patients who undergo blood transfusions. So I highlighted in red the complications that we see in surgical patients. Obviously, we can see all the complications in surgical patients, but the complications that come up in the perioperative period and that are important with regards to the surgical patient population. Infectious complications of blood transfusions include viral, bacterial, parasitic, and prion. I'm going to discuss a few. And as I said, the non-infectious complications, TRALI and transfusion-associated circulatory overload, those, if not managed appropriately, are associated with a high mortality rate. The allergic transfusion reactions are the commonest complications that we see. And then I'll speak a bit about graft versus host disease, this entity of transfusion-associated graft versus host disease. So with transfusion-related acute lung injury, it's defined as an acute lung injury that occurs within 6 hours of a blood transfusion. The estimated incidence is about 1 per 1,000 transfusions. The pathophysiology has been well described. It's thought to be due to anti-neutrophil antigen antibodies present in plasma in the donated blood and anti-HLA antibodies. These antibodies bind to class 1 and 2 MHC, making the neutrophils more stiff. The neutrophils then form immune complexes. They become activated and they release elastase and hydrogen peroxide into the circulation, particularly into the circulation of the lung. And this elastase and the hydrogen peroxide then cause endothelial damage and cause extravasation of protein-rich fluid into the alveolar space. TRALI is characterized by lack of left atrial hypertension, bilateral infiltrates on the chest X-ray, and hypoxemia. Its central feature, as I already alluded to, is the increased permeability in the pulmonary vasculature with extravasation of protein-rich edema fluid into the lungs. Patients typically improve clinically within 48 to 96 hours after the onset, with resolution of these infiltrates and no long-term adverse effects. Due to the associated underlying conditions that many of these patients have, the mortality rate is estimated to be around 5 to 15%. Now, blood transfusions induce immunosuppression. The concept of immunomodulation related to blood transfusions was sparked by the observation that renal transplant patients had improved graft survival if they underwent transfusion before the transplantation. It was also the mechanisms for this observation is incompletely understood. But there's also observational studies that have demonstrated that an increased risk of post-operative bacterial infections occur in patients who received blood transfusions in the perioperative period. And this is thought to be due to this entity of blood transfusions inducing immunosuppression. There is a proposed mechanism, and it's thought that the transfusion-related immunomodulation is due to the immunologically active donor white blood cells that are present in the blood transfusions, and also the soluble white blood cell-derived immune mediators in the stored blood. What they found in one randomized controlled trial was that they gave some patients leukodepleted blood transfusions, and they gave other patients leukoreplete blood transfusions, and patients that were undergoing surgical procedure that had leukodepleted blood ended up with reduced multi-organ failure and mortality. So they think that the white blood cells and the white blood cell components that are transfused with the red blood cells have an effect on the body and cause immunosuppression. I'll just quickly go over the other transfusion reactions that we can see in the perioperative period. The commonest, as I said, is the simple allergic reactions. Its incidence is about 1 in 100 transfusions. It's a type 1 hypersensitivity reaction or an immediate hypersensitivity reaction, where the B lymphocytes will produce IgE antibodies in response to allergens in the transfused blood. And these are sometimes plasma proteins. The reactions are usually mild. The transfusion can be stopped. You can administer antihistamines to the patient, and when the symptoms resolve, you can recommence the transfusion. This is in contrast to anaphylactic transfusion reactions, which are very rare, but are very dangerous and can be lethal if not managed appropriately. They are thought to occur as a result of anti-IgA antibodies in the recipient. So what the proposed mechanism is that certain individuals in the population are IgA deficient. This can either be congenital or acquired, and then they develop anti-IgA antibodies, usually due to pregnancy or previous blood transfusions. And then when you administer blood with IgA in it, there's an antibody-antigen reaction, and this causes anaphylaxis. Not all patients with IgA deficiency will get anaphylaxis if you give them a blood transfusion. Only certain patients develop anaphylaxis, and therefore IgA deficient blood products or saline washed red blood cells are only recommended to be used in patients with IgA deficiency who had a previous anaphylactic reaction. IgA deficient blood products are not easily available, not routinely available, so they're difficult to get. Then we have febrile non-hemolytic transfusion reactions. These are thought to be due to transfusion of leukocyte antigens or pyrogenic cytokines that accumulate in stored blood. And then the acute hemolytic transfusion reactions, which is a result of transfusing incompatible red blood cells to the recipient. It's estimated to occur 1 in 6,000 to 20,000 transfusions. And the hallmarks and symptoms are fever, chills, hypotension, hemoglobinuria. Some patients may get renal failure, back pain, and DIC. Then I'm just going to speak a little bit about delayed transfusion reactions. They usually occur 1 to 3 weeks after a transfusion, and they are due to antibodies to the minor blood group antigens, such as anti-Duffy or anti-KID antibodies. So some patients may have these antibodies that they produced in response to a previous transfusion, but they may escape detection when we cross-matching the patient due to a rapid decrease in their titer over time. And when you give them blood that contains Duffy or KID or other minor blood group antigens, there's an anamnestic immune response, which basically means upon re-exposure to the antigen, the memory B cells can take 5 to 10 days to produce these antibodies, and then you get this delayed hemolytic transfusion reaction. Severe reactions are very rare. There's no specific treatment, and the overall prognosis is excellent. Discuss transfusion-associated graft versus host disease. It's a rare but lethal complication of blood transfusions. It's due to the transfusion of lymphocyte-containing blood products. So all blood products we give patients may contain a small level of lymphocytes from the donor, specifically red blood cell concentrate. The onset of symptoms is usually 1 to 2 weeks after a transfusion, and the classical symptoms are those of the general graft versus host disease, so skin rashes, diarrhea, fever, and hepatitic blood picture. But in particular, transfusion-associated graft versus host disease is characterized by severe bone marrow hypoplasia leading to pancytopenia. What basically happens is you give an infusion of maybe a red blood cell concentrate, and then with that, there's some immunocompetent lymphocytes that get transfused into the recipient. The recipient may be immunocompromised and may be unable to clear those lymphocytes. So a normal immunocompetent recipient will clear those lymphocytes very quickly from the circulation. But an immunocompromised recipient will not be able to do that. There's then engraftment of the donor T lymphocytes in the recipient and proliferation. And then the donor T lymphocytes then recognize the recipient cells as foreign and attack the recipient's tissue. So it obviously can occur in immunocompromised hosts because they can't clear those foreign lymphocytes. And it can also occur in immunocompetent hosts, and this is where surgical patients come in. So in one way, it can occur in immunocompetent hosts when the donor is homozygous and the recipient is heterozygous for an HLA haplotype, and therefore the recipient does not recognize the donor white blood cells as being foreign. It doesn't destroy the infused lymphocytes. I'll come back to cardiac patients in a moment. Just a bit about the pathophysiology. So the donor T lymphocytes then engraft in the recipient. The host antigen presenting cells will then present host antigens to donor CD4 and CD8 positive cells in the lymph nodes. These are then recognized as foreign. Host antigens are recognized as foreign. There's activation, proliferation, and migration of the donor T lymphocytes. They release large amounts of interleukin-1, interleukin-2, and tumor necrosis factor alpha. Tumor necrosis factor alpha is the key inflammatory cytokine. It recruits and activates the effector cells, which is the CD8 positive cells and the natural killer cells. And then this causes target cell apoptosis. This cytokine storm is what leads to widespread tissue damage. Now, there's a whole host of risk factors for developing transfusion-associated graft versus host disease. I'm not going to go into all of them. One we said is having a similar HLA haplotype. The donor having a similar HLA haplotype to the recipient, and this is seen when family members donate blood products. The second area it's seen in is patients undergoing any surgery in which cardiopulmonary bypass is required. And this is the commonest cause of transfusion-associated graft versus host disease in immunocompetent patients. In this group of surgical patients, the use of fresh blood products is seen to be superior. And what basically happens is when blood is aged, the lymphocytes tend to lose viability and die off. But if you're using fresh blood products in a patient, those lymphocytes are very viable. The second way in which it's thought to cause this problem is that cardiopulmonary bypass appears to produce a transient state of immunodeficiency. It causes reduced interleukin-2 production, and then there's this entity of reduced mitogenic lymphocyte transformation in these patients. I'm not going to go into detail on the infectious complications of transfusions. Just suffice to say, there was a recent article in the British Journal of Hematology in 2008, which described that infectious complications, as we all know, have drastically reduced due to the sophisticated blood screening methods that are currently available. Historically, until 2009, the main transfusion-transmitted infection was bacterial transmission. But recently, especially in the developed countries, hepatitis E has predominated. Hepatitis B is the major non-bacterial risk of transfusion-transmitted infections. In the UK and the USA, it's thought that the risk of getting hepatitis C infection is about 1 in 40 million, so it's very small. The risk of acquiring HIV from a blood transfusion is about 1 in 4 to 5 million. And the risk of getting hepatitis B virus from a blood transfusion is 1 in 1.3 million. So the risk exists, but it's currently very small. Transfusion-transmitted bacterial infections are more important in the perioperative period, and in particular in the post-operative period, because patients are more at risk of getting wound sepsis and getting septicemia and septic shock and renal complications. So we said that the transfusion-transmitted bacterial infections, now they are rare, but when it does occur, it's a significant cause of morbidity and mortality. It occurs more commonly with platelet components and with plasma products, because platelet components are stored at room temperature and bacteria grow well at room temperature. And also these products are derived from multiple donors. So the risk of bacterial infection is higher. Skin flora accounts for more than 90% of platelet-associated transfusion-transmitted bacterial infections. The sources of these bacterial infections are bacterial contamination from maybe the donor arm at the time of blood collection, donor bacteremia, which is rather rare because if patients are sick, they're not usually donating blood, and rarely contamination during the processing of the blood products. I thought this was quite interesting, and I didn't know this. Yersinia enterocolitica is a bacterial human pathogen that can grow at 4 degrees Celsius, and therefore it may be transmitted via red blood cell concentrates that are stored at low temperatures. It's associated with a 55% mortality rate. It was found to have affected 55 blood donations from 1975 to 2007 in the UK. So if a surgical patient, post-operative patient, is suspected of having sepsis and you culture this organism, then you should be thinking of a transfusion-transmitted bacterial infection. Hepatitis B virus, previously it was the commonest virus to be transmitted via blood products, but currently due to nucleic acid testing, this has reduced the risk of transmission even further. Occasional transmissions can occur if the donor viral loads are below the level of the test detection, but it's very uncommon. So I'm going to speak a bit about the impact of red blood cell transfusions on mortality after cardiac surgery. Transfusion, red blood cell transfusion I'm talking, like anemia, is an independent risk factor for morbidity and mortality after coronary artery bypass graft. Even if short-term survival is disregarded, so we disregard all the short-term complications of blood transfusion, the long-term survival after cardiac operations is also negatively affected by perioperative red blood cell transfusions. And this was described in particular in patients who underwent coronary artery bypass grafts. A study of 8,598 patients found that even after the exclusion of deaths within 1 year of the operation, there remained a significant impact of perioperative transfusions on increased subsequent mortality. The age of the red blood cells used is another important concept. A propensity-matched analysis demonstrated that transfusion of red blood cells that had been stored for more than 2 weeks was associated with an increased risk of post-operative complications and with short-term and long-term mortality. So they're saying that if these surgeons used stored blood, it's associated with increased risk of complications. And then we also described that if you use fresh blood, it's associated with increased risk of graft versus host disease. So there's complications on both sides. Now, what are the impacts of blood transfusions on the morbidity in patients who undergo cardiac surgery? Perioperative blood transfusions have been associated with increased morbidity. Perioperative red blood cell transfusions have been identified as an independent risk factor for post-operative atrial fibrillation after cardiac operations. The rate of infectious complications, including bacteremia, sternal wound infections, and Clostridium difficile-associated diarrhea, has also been shown to be increased in those receiving blood transfusions. With regard to the pulmonary morbidity, there was higher risk-adjusted rates of post-operative respiratory distress, respiratory failure, acute respiratory distress syndrome, re-intubation, longer times on the ventilator. All these have been demonstrated in patients undergoing transfusions. In another analysis of 11,963 patients who underwent coronary artery bypass graft, the risk-adjusted rates of post-operative renal failure and neurologic events were higher in patients undergoing transfusions. And I also thought this was important. An analysis of 12,388 patients undergoing cardiac surgical procedures found that the risk of acute kidney injury increased proportionally with the number of red blood cells transfused. So if you're going to transfuse red blood cells in the perioperative, then they looked at Jehovah's Witnesses and cardiac surgery. An important study that used propensity matching found that Jehovah's Witnesses undergoing cardiac surgical procedures had fewer acute complications, and this included fewer myocardial infarcts, fewer reoperations for bleeding, less prolonged ventilation, a shorter length of hospitalization, and an improved 1-year survival. And this was when compared with well-matched patients who were receiving blood transfusions. I'm going to discuss a bit about allogenic blood transfusion and non-cardiac surgery. In a prospective study that collected data from 6,301 patients undergoing non-cardiac surgery, allogenic blood transfusion was associated with increased post-operative pneumonia, increased length of hospital stays, and increased mortality. Multiple subsequent studies confirmed that there's a dose-dependent relationship between allogenic blood transfusions and a composite outcome of myocardial infarction, stroke, pulmonary complications, renal complications, sepsis, thromboembolic complications, and wound complications. A bit about allogenic blood transfusion and post-operative infections. So we spoke about immunomodulation. Allogenic blood transfusion leads to immunomodulation of the innate and the adaptive immune system after exposure of the recipient to the many cell-bound and soluble antigens expressed on viable and decaying cells in the transfusion. Allogenic blood transfusion has also been associated with infectious complications after operations for gastrointestinal and pancreatic cancer, hip replacement, and spinal fusion. The odds ratio of post-operative bacterial infection was 3.45 subsequent to allogenic blood transfusion. So in conclusion, there needs to be a move towards decreasing the number of blood transfusions that surgical patients receive across the board. And this can be done by the improvement of techniques of blood conservation in surgical procedures, implementation of patient blood management, and protocol-driven blood transfusion algorithms. Thank you.
Thank you, Sarita, for a very comprehensive presentation. I have two questions in the chat box. The one is from Yaglin Naidu. It says, thank you for the talk, blood transfusion risk in the surgical patient. I have noticed from audits that the doctors ordering blood and casualty for a surgical patient usually overestimate the required compared to what the surgeon and anesthetist in the operating theatre would require. These units tend to be returned late to blood bank and then has to be discarded. There does not seem to be a universally accepted surgeon and anesthetist minimum blood ordering schedule for surgical trauma versus non-trauma patients, and the use of the appropriate BRB in the setting. Second comment, label errors and casualty because of multitasking by junior doctors have resulted in possible transfusion reactions. Blood bank has a check mechanism if patient was transfused previously. Bedside errors are preventable and training is important. So that is a bit of a comment. And then Perry asked, our blood services are mandated to provide the safest blood products possible. What is your opinion on universal leukoreduction of blood products, Sarita?
So it's a very expensive exercise to leukodeplete blood across the board. I don't think it's going to be feasible in our setting. I think that clinicians should be able to gauge when patients need leukodepleted blood. Not everyone needs it. Not everyone gets recurrent blood transfusions. Obviously, it would be better in patients who are undergoing cardiac surgery because of the increased risk of graft versus host disease. But in patients, in non-hematological patients who are not getting recurrent blood transfusions, and in non-cardiac surgical patients, I don't think it's mandatory.
Thank you, Sarita.
I could just quickly comment, Jan Gert.
Yes, Prof. Lau?
Yeah, I agree. I do think that with the increasing knowledge that we're gaining about the side effects of non-leukodepleted blood, in an ideal world, if cost was not an issue, we would have liked to do universal leukodepletion. But like Sarita said, it's basically a function of price. And just to let you know that the evidence for leukocyte depletion on the development of GVHD is actually not that strong. So we used to always think that this is really a good way to prevent it, but the evidence is not really very strong for that. So for now we use it when indicated, but yeah, in future I hope that we will be able to get it done more cost effectively so that everyone can get it.
Thank you for that comment, Prof. Next question is from Lev. He's asked, is there a role for irradiation of blood products where the facility is available? Sarita?
So I think that ideally, immunosuppressed patients benefit from irradiated blood products. But if a patient is just getting a blood transfusion, for example, in the trauma scenario, and it's just once off, then I don't see the need for irradiated blood products. So it should be a patient-specific indication because it's also quite expensive.
Thank you, Sarita. I agree. Do you know if there's any evidence for the use of ruxolitinib in transfusion-associated graft-versus-host disease? Question from Moses Shatumbutsa.
Jan, I'm not sure about this.
Neither am I. Prof. Loh, do you know?
Moses, I think that's a great question. So ruxolitinib has turned out to be one of the most effective treatments for graft versus host disease in the stem cell transplant setting. But at the moment, I'm not aware of any studies or any, well, it will not, we won't find studies, that I can tell you already, because fortunately transfusion-associated graft versus host disease is so rare that I think it will be impossible to design one. But nevertheless, I'm not aware of any studies or any case reports on its use, but I will have to go and look. The number one preferred treatment would be a bone marrow transplant, as a matter of fact. The challenge is just that it's not practical. You know, these patients are so sick, and it's a almost universally lethal problem. To find a donor that quickly and get everything up and running is very difficult. So mostly people use things like cyclosporin or ATG or photopheresis or whatever the case may be. But it's a good point. And I think if one runs into such a patient, it may be something to consider in addition to some of the other therapies. But that's now, you know, sucking hard on my thumb. I'd love to hear if any of my fellow hematologists or colleagues at hematopathologists have another suggestion on that. What does Prof. Johnny Mshlangu say?
Then I agree with you completely.
Sounds as if we're in agreement, Prof.
Good. Just from an exam point of view, just to let all the HemPath and Hem fellows know, I think it is quite important to have a good understanding about the need for blood product irradiation and the indications, of which there are quite a few, and that we use every day in a hematology setting. And second, I think it is important to have a knowledge of leukocyte reduction or leukocyte depletion, and in which indications benefit has been shown, where benefit is uncertain, and where there is no benefit. Makes a nice question, I think, and it's also important to know from a practical point of view.
Hi guys, it's now my turn. Yeah, I dreaded this actually, because I mean the amount of stress we all have. It's like that fear for negative evaluation by peers. But I will try my best, and I will try to share a few messages on clinical decision support and improved blood use and patient blood management. Now, I see these two entities actually as closely linked, because just having made good evidence-based plans on its own represents an exercise in futility in my eyes if you do not have a functional and rational way to aid in promoting its acceptance and implementation. Oh, sorry, my screen doesn't want to, I'll say. In order to improve the clinical practice regarding the administration of blood transfusion, more interventions than the mere issuing of guidelines are necessary. Today, during our dive, I'm going to speak about two such initiatives: the advent of the use of clinical decision support systems and the consideration of patient blood management as the standard of care. The efficacy of these entities are interlinked and interdependent. The American Medical Association has identified blood transfusion to be one of the 5 most frequently overused therapies. The cost associated with allogeneic blood transfusion, as we've heard from the previous 2 talks, isn't something that can be merely measured in monetary terms, but also need to be measured in terms of patient well-being, where transfusion was linked with adverse clinical outcomes. And to make it even worse, limited evidence for the efficacy of red cell transfusion outside the setting of acute blood loss is available. In 2009, the Institute of Medicine in America and the United States estimated that 30% of healthcare spending, amounting to about $750 billion per annum, was wasteful and unnecessary. Blood transfusion was the most frequently performed procedure, with a significant percentage of these being deemed as inappropriate. A large Cochrane meta-analysis that included 19 trials with about 6,000 patients showed that restrictive strategies were equivalent to liberal transfusion policies in most patient groups. Traditionally, retrospective reviews of blood component use was initiated by transfusion services, with the results being reported to institutional transfusion committees for oversight. Appraisal of a small sample of cases sometimes did not accurately reflect prevailing transfusion practices. And retrospective review on its own did not modify future behavior without continuous follow-up and feedback. Clinical decision support systems allow us to have a in real-time evaluation of transfusion practices. Strategies that have been tried to improve transfusion practices included institutional guidelines, educational programs, and physician audits of transfusion orders. But success of these interventions are variable, or were variable. Something more definitely needs to be done. Was influencing transfusion practice and human behavior in general requires ongoing assistance and education. And we, from the previous 2 talks, we have been really reminded that less is really more in transfusion. In a hospitalized non-bleeding patient, the American Association of Blood Banks do advise the transfusion of a single unit at a time, and this transfusion would be followed by reassessment. This practice actually has a greater impact on red cell use than restrictive policies. There are several problems with trying to effect change in clinical behavior. The one being, it takes time. The average amount of time that it takes for at least 50% of United States clinicians to adopt a published guideline is actually 17 years. Often people implement change for a while and then regress to what seemingly worked before, regression to the mean. And that leaves the average adherence to published guidelines in the US to be about 54%. We all know that generating evidence and guidelines costs lots of money and time. Looking at clinical decision support, we do know that information technology has become increasingly prevalent in all industries in life, especially in the healthcare arena. Clinical decision support systems they are used to augment clinicians in complicated decision-making processes. Clinical decision support systems were developed to provide patient-specific, evidence-based, advice in order to overcome the challenges facing the healthcare industry, such as, well, diagnosis, medication prescribing effectiveness, and to reduce medical errors. These systems generally rely on 3 pillars, and one of them is having the best knowledge available when needed. And in that process, we need to utilize and establishing evidence-based medicine. This process is also really reliant on continuous improvement the whole time. As new evidence becomes available, the system needs to be adapted. And this system will not work if people or clinicians do not adopt it and use it effectively. Clinical decisions support is administered through electronic medical records and other computerized clinical workflows. The provision of tailored feedback serves more than one purpose, in that it's educational and a safety delimiter. Clinical decision support improves healthcare delivery by enhancing medical decisions with targeted medical knowledge. The use of electronic medical records implicitly promised advanced data analysis to further patient care and actually to prevent unnecessary treatments. Its use enabled tailored feedback to the provider at the critical time of order entry to promote appropriate use. It has been shown to be effective in altering triggers to transfusion. Clinical decision support systems have been classified and subdivided into various categories and types, including intervention timing and whether they have active or passive delivery. In knowledge-based systems, rules with phrases like the if-then statements are created with the system retrieving data to evaluate the rule, producing an output. Rules are made using literature-based, practice-based, or patient-directed evidence. Clinical decision support systems that are non-knowledge-based still require a data source, but the decision leverages artificial intelligence, machine learning, and statistical pattern recognition. It's almost like my car's GPS, knowing on a Friday that I need to navigate to my local sushi supplier. It is not necessarily precise or always right, but it gives a good estimate. In order to demonstrate the utility of this clinical decision support systems, I will demonstrate the effects of its application by Goodenough and Hollenhorst. They demonstrate a cost saving in the transfusion of red blood cells. Smart best practice alerts were triggered when a provider ordered a red blood cell transfusion for patients with a pre-transfusion HB of 7 or 8. And this was specifically performed in patients with acute coronary syndrome or cardiothoracic procedure. The alert provided a reminder that transfusion with a single unit of red blood cells was preferable. The patient's most recent laboratory results with a hemoglobin concentration was provided. The alert also provided an acknowledgement reason drop-down query that required the ordering physician to provide an answer as to why the red cell transfusion was ordered, be it the hemoglobin value, bleeding, or they had the option of other. The hemoglobin threshold was asked to trigger a review by the ordering physician of his or her own practice, and not necessarily to establish a new hemoglobin transfusion value. Subsequent to the implementation of the best practice alert prompts, the percentage of transfusions with an HB more than 8 decreased from 60% to less than 35%. The reduction was evident when transfused red blood cell units were determined per number of patient days at risk. And a significant downward trend was registered from 2011 through to 2015. The researcher did witness a significant reduction in hospital-wide mortality, although they do remain cautious about this finding. With they just maintain that association does not prove causation. Major problem that was experienced with this clinical decision support system was alert fatigue. Yeah. During 2011 to 2012, 98% of all best practice alerts were overturned, and with the likelihood of accepting a best practice alert dropping by 30% for each additional reminder received per encounter. This is just something that underlines the fact that physician ordering systems need to be tailored. Clinical decision support in patient blood management just show that real-time clinical decision support leads to reduction in the number of inappropriate transfusions and its related costs. We all know that restrictive transfusion practices, then they inferred that it could be applied institution-wide. The pitfalls associated with this clinical decision support included a disrupted workflow. It's seen with standalone systems and also systems that were designed without human information processing and behaviors in mind. Disrupted workflow can lead to an increased cognitive effort with more time requested to complete tasks. Studies found that up to 95% of clinical decision support alerts are inconsequential. That is a difficult stat to swallow. It is important to consider also when you implement a clinical decision support system to consider the long-term effect of clinical decision support on users. On the one hand, clinical decision support might train the users so well that it's not needed over time. And conversely, users might develop too much reliance on a clinical decision support system for a specific task. And this might be potentially problematic if the user has to work at times without the application of a clinical decision support system. In a different study, where they also looked at real-time clinical decision support, and it was done in hospitals in Stanford. The researchers found comparable results to the current example, and clinical decision support was also effective in improving red cell utilizations at a pediatric and an adult population. But the problem that still persisted is that 30% of transfusions still occurred in patients with an HB of greater than 8. Clinical decision support will require continued maturation to optimize user engagement, and we really need to find a way to minimize alert fatigue. Big word in the previous two presentations was patient blood management. We need to make patient blood management a part of our everyday vocabulary to optimize patient outcomes and to help an equitable spread of our often very limited resources. An early drive of exploring measures for blood conservation and the avoidance of transfusion was found in the need to provide modern, safe, and effective healthcare to those individuals objecting to transfusion on religious grounds. The World Health Organization defines patient blood management as patient-focused, evidence-based, and a systemic approach to optimize the management of patients and the transfusion of blood products for quality and effective patient care. We also have an alternate definition that focuses on the 3 pillars of patient blood management, where timely application of evidence-based medical and surgical concepts to maintain hemoglobin concentration, optimize hemostasis, and minimize blood loss in an effort to improve patient outcome. Patient blood management does represent a relatively new paradigm in transfusion, and we know that real data shows that patient blood management improves patient outcomes and saves money. The demonstration of a dose-dependent relationship with adverse outcomes with transfusion is something that sways the debate in the direction of patient blood management. They've also not seen a benefit of liberal transfusion regimens when you compare it with restrictive regimens. And a number of large observational studies have demonstrated significantly improved outcomes with the restrictive blood transfusion policy. Patient blood management has shown improved outcomes while reducing the cost and or resource utilization. This table is stolen from a recent publication in the South African Medical Journal. And the authors argued for the implementation of patient blood management in South Africa, because we know that patient blood management has the potential to address several healthcare challenges that are specific to our country. And what I found really striking in the article is that perioperative anemia is very prevalent in our country at about 48%. And we know that perioperative anemia is associated with an independent increase in hospital mortality, in-hospital mortality and admission to critical care. And then the Frankfurt Consensus Conference took place in April 2018. And in this Congress, they focused on 17 population intervention comparison outcome questions. The questions encompassed red cell transfusions in adults with a focus on preoperative anemia, transfusion thresholds, and the implementation of patient blood management. It's the hematology mindset, PBM. They found on preoperative anemia, they did a massive review of large tranches of literature. They basically, as a major recommendation, found that preoperative anemia needs to be detected and managed early for major surgery as a strong recommendation. They found the use of iron supplementation in adult preoperative elective surgery patients was suggested, and they suggested that conditionally. They also advised against the routine use of erythropoietin agents in patients undergoing elective surgery. But they did also add that consideration should be paid to the use of short-acting erythropoietins in addition to iron supplementation in elective major orthopedic surgery. They found that restrictive red cell thresholds for HB less than 7 in critically ill but clinically stable ICU patients. They set the restrictive red cell threshold of an HB less than 7.5 in cardiac surgery patients. They also suggested the restrictive red cell threshold of HBs less than 8 in patients with a hip fracture and cardiovascular disease and other risk factors. And finally, they also said restrictive red cell threshold with an HB between 7 and 8 in hemodynamically stable patients with acute gastrointestinal bleeding. They recommended the implementation of patient blood management programs to improve appropriate red cell transfusions. And they also recommended the use of computerized electronic decision support systems to improve appropriate transfusions. Patient blood management has the potential to address several healthcare-related challenges, specifically to South Africa, where we saw population growth with a high burden of anemia. The implementation of patient blood management, including anemia management and bleeding management, are opportunities to sustainably improve healthcare in our country. patient blood management would also ease pressure on our blood supply, with economic arguments for patient blood management, including the burden of disease of unmanaged or untreated anemia. And we do know that despite worldwide recognition of the value of patient blood management, there remains room for improvement with regards to widespread adoption. Comprehensive implementation of patient blood management remains challenging because it involves patients with a wide range of clinical conditions undergoing many different procedures in many different settings. And the article also just alluded to that patient blood management activities requires coordination, and they, funnily, they questioned, they said not mandatory, not definite, but there needs to be somebody to coordinate this whole effort. We do know about the clinical decision support and improved blood use in patient blood management with improves the execution of patient blood management and can be counted as a meaningful contributor to gains that have been made. Both these interviews, I think, is really necessary in our country, in spite of the fact that we don't have widespread electronic patient records necessarily, but that is something to work towards. And these are my references. Oh, come on. Okay. Okay. The first question I see here, sorry, did somebody have to say?
Yeah, I just want to say thank you very much, Jan Gert. And because you were the speaker, I'll maybe quickly deal with some of the questions that were asked.
Thank you, Prof.
Dr. Moses Chatambutsa was asking how applicable are restrictive transfusion protocols in the majority of our outpatient hematology patients with MDS, aplastic anemia, myelofibrosis, and pure red cell aplasia. What pre- and post-transfusion targets would be ideal to optimize quality of life of patients?
My answer, and that is not necessarily evidence-based answer, but I feel that it is a different patient population that you're speaking of. Yeah, I mean, these are patients that do not have factories or have defective factories in terms of blood cell generation, and you treat the patient, not the count. And I mean, you treat symptomatic anemia, you will treat. I still feel that it's a good policy to reevaluate after every unit of blood you transfused. But I do not think the specific restrictive guidelines can be really applied in, say, somebody who's an aplastic anemia patient or a patient with myelodysplastic syndrome. I feel that you transfuse those patients until they're not symptomatic, and then you follow them up.
Yeah,
and I wonder if I could say something. Hi,
yes,
sorry. Yeah, it's Debbie. So I was thinking about that question as well, and I agree with Jan. I think our patients have the irreversible, most of them, kind of anemia, and I think to treat the patient just based on the hemoglobin value would be the incorrect thing to do. That you'd actually have to take each patient as an entity in their own and see at what level they function on their anemia or the hemoglobin level. So yeah, I think for quality of life, it would really be patient dependent, and those targets would be interchangeable.
Yeah, Debbie, I want to agree with you there, and also with Jan Gert, to individualize there's obviously a balance of risks here. Again, we're dealing with patients who are chronically transfused, and with enough transfusion, they're going to get iron overload. They're going to get HLA sensitization. So a lot of challenges in the long term. So individualized, and it could mean that for some patients, an HB of 6 may be fine, whereas for others with cardiovascular disease, an HB of 8 or 9 may be necessary. So there's very little, surprisingly, done in terms of patient blood management in the hematology setting, surprisingly enough. There is one study that looked at the acute leukemia transplant environment, where they also found that keeping the HB using a restricted threshold of 7 rather than a higher threshold was no worse than a higher threshold. So in our unit, we would usually look at the patients clinically. We give single unit transfusions, one at a time, and only on clinical, ongoing symptoms, we would add more units. And that's for many patients, an HB of between 6 and 7 is totally tolerable if they're in bed, they're not running around climbing walls and all sorts of things. So I see we've got 2 hands up. Let me just quickly see who that is. I think I saw Prof. Johnny Mshlangu earlier, and then Dr. Irma Pillay. Johnny?
Thank you, Vernon. I just want to echo, I think, the last comment you made. No, first of all, thanks, Jan Gert. This is a very provocative topic. But the point you made is that it would seem that PBM is meant for the surgeons and not for everyone else. I mean, that's a conversation I had with one of our surgeons here, that because they follow certain protocols, they can be audited. It looks like, in fact, the bulk of the PBM is aimed at them and not at anyone else where there is clear wastage associated with the use of blood and, of course, poor outcomes. I mean, the specific example he gave was the high mortality that we see in patients with cancer. Whilst we all agree, and I think that's the sentiment that was expressed by Jan Gert and you, Vernon, that you have to individualize, you give the patients what they need. But in relation to the outcomes, if we were to compare that to the surgical interventions, they are miles apart. And certainly if we're to do an audit of what kind of impact does transfusion do to the quality of life of our patients and or even life extension, you might find that in fact the surgical disciplines are doing much better. And that worries me, coming from obviously someone who's given this. By the way, the person I had a conversation with was the dean of our faculty, Martin Vella. He's a vascular surgeon. And we had a very long academic discussion around it. So that was his impression, which I must admit, it was an eye-opener. But it's true that we tend to focus on these things, largely on where the surgical interventions are being used rather than in hematology. Vernon, you're absolutely right. I went through and I looked to see if there's anyone who's ever done patient blood management in the context of hematology, and there aren't any studies. So we just need to put that conversation into perspective. The one provocative sort of question I wanted to ask Jan Gert. It sounds like clinical decision support can all be done by a computer. Are we looking at the near future where there will be extinction of all of us as clinicians?
No, Prof. Mshlangu, I don't think so. With the clinical decision support system, I know it's not AI or whatever not else. This is the knowledge-based system that is utilized here, and it is merely suggestions. Because at the end of the day, it remains the treating clinician's decision to transfuse or not to transfuse. I could say it in more crass terms, but I think that we all have the right to make our own mistakes. I do agree with you, though, that generally speaking, patients going in for surgery have got more of a bone marrow reserve, generally speaking, now than your average hematology clinic patient. So I do feel that you have a very valid point there, or you're underlining a very valid point. I do think that artificial intelligence or those things would start to impede on lots of things that we traditionally see as a human domain. But I do believe that at the end of the day, somebody still needs to check up on the AI or whatever program or system has been put there. So I think that we still have work for a few years to come.
Thank you.
I just want to quickly comment on that before I go to Irma and then to Johan Potgieter. So there's a very simple, many of you know this, but a very simple blood accountability form that has been developed by Dr. Rob Wise at Edendale Hospital, through which they were able to make doctors accountable for the blood they ordered, and through their blood utilization committee also give feedback to departments. Please, and what they found was that they saved in a period of 2 years 4,400 units of blood in the secondary level hospital, 15 million rand saved in the first 2 years. They reduced their total blood expenditure by 39% and also their blood use by 36%. And they funded 8 MO posts with that money and with that saving. So we have made quite a bit of inroads as a larger PBM team in Cape Town and Western Cape as well. And it's the savings, the projected savings for this year is between 35 and 40% in blood products. And we're talking about more than 110 million rand saving for the Western Cape and 30 plus million saving for Groote Schuur Hospital alone. So there's huge things to be gained. And we haven't even implemented the blood accountability form yet, but we are going to be piloting that. And I think there's very exciting things. And I think we as doctors must lead the way and say to each other, we need to be accountable. We now know, like our 3 colleagues showed us today, that outcomes are worse for many, many groups of patients if we do not give them the alternatives that are appropriate and, when it is appropriate, and that patients will do worse. And I don't want to have my family members be in the category that is getting the transfusion when an alternative is available. So I really want to thank the 3 colleagues from Pretoria for a wonderful job in showing us that today. Dr. Pule, Irma, she's a fellow at our unit in Groote Schuur.
Hi, thanks Vernon. I on a much smaller level, I just wanted to make a comment and maybe share and maybe ask if I did the right thing today. So I sat down with a very intelligent with a patient today. She's a low risk multi-lineage myelodysplastic patient of 44 years old. And she's just been taken off the bone marrow transplant list for the moment because of her low risk and only having haplo options and very low transfusion requirements. In fact, since she was diagnosed in April with us, she hasn't required a transfusion. And for the first time today, her HB dropped down to 7. And I noted that she's tachycardic. At the last visit 2 months ago, her HB was, as always, around the lower 8.1, 8.2. Today it had dropped down to 7. And she also previously had a heart rate of 87, and today it was around 111. So because the patient is intelligent and she wanted to know what happened at the transplant meeting, we sat and we discussed the pros and the cons and her symptoms, which didn't seem markedly different from before. With the HBs, I made a point of actually asking her about her symptoms before I told her what her HB was, to not let that influence her, symptom burden. And we decided against transfusing her today and following her up in 1 month's time and seeing basically how low we can go, to know what her cutoff is before we start intermittent transfusions. So keeping this in mind, I would like to just explain, like in a practical way, or just give an example of what I sat with today in clinic. It was nice because the patient is actually intelligent, and we made a joint decision that she will contact me at any time if she feels too tired and too exhausted to carry on without the transfusion. And then somebody also asked on the group today what we did at Groote Schuur to implement patient blood management, and Prof. Louw can maybe supplement to what I say, but this is exactly it. He has created an awareness in all of us of the use of blood products. So we all are only, very rarely, we are transfusing more than 1 unit at a time. We, in the transplant unit, which is a big user, we have a transfusion, automatic transfusion cutoff of 6, but obviously a little bit more lenient towards patients with symptoms. And usually we preemptively order when we see the HB decreasing towards 6. Then we also do not transfuse. We previously transfused, because I was here before Prof. Louw came, and we used to transfuse at a level around 20 for platelets, but nowadays we still transfuse around 20 for septic patients, but for anyone else, we allow platelets to go no lower than 10. But it's also, I think, impacted on our usage. So it's a lot lower than we used to, and in the ward similarly. But the main thing is the awareness and the care that goes into ordering and thinking about every unit that is transfused.
Thanks very much, Emma. I'm just going to make a quick comment. So I think what you've demonstrated is exactly what we want, is a individualized, careful evaluation of the patient clinically. Hemodynamic instability would usually be an indication to transfuse, and tachycardia may be an indication that the patient is starting to struggle. And what you're now sitting between two difficult places. On the one hand, you want to limit blood use and really be careful with giving, but on the other hand, you don't want the patient to develop cardiac remodeling and a tachycardia-induced cardiomyopathy. So I think in this case, your patient has been well counseled to come back. But generally speaking, if the tachycardia is, if you think the tachycardia is due to the anemia and the patient's got an HB of 7, I would probably give a unit of blood, because I wouldn't want that patient to walk around with the tachycardia for a long time. And if it's only the anemia that's causing the tachycardia and the patient's got a bone marrow failure syndrome, then I've got no reason to think that tachycardia is going to disappear. And tachycardia-induced cardiomyopathies can actually develop within weeks in the worst case scenario. So one has to be just a little bit careful with that. But yes, maybe I've been very forceful with my message, but I think this is a nice case to point out that one has to balance it. And importantly, like you've done, like you always do so well, communicate well with your patient so that they can know they can come back immediately if needed. I hope that answers your question in part. Johan.
Yes, thanks, Vernon, and thank you for everyone's contribution. I would like to perhaps say my view on this is that it is a spectrum. And I agree completely that you have to individualize. The problem is that I think that if one is too stringent also, then you run the risk of perhaps not supporting a patient when the patient should in fact be supported. And I think that in future, if we look at PBMs, we're probably going to see a little bit of that, and we're going to have to find our own middle ground, as it were, to be safe enough. In terms of what Moses has asked, and he asked, in our setting, how restrictive should we be with transfusion protocols, and what should the target or the threshold actually be in our patients? And that's a difficult thing. So first of all, we don't measure, and I think that's something that we have to actually do, measure the quality of life of our patients. It can be disease specific, but the second thing is that often I think we are caught between a rock and a hard place, because we would like to transfuse single units, but the problem in our setting is that there are no beds. You can never find a bed to admit a patient in. We don't have a short stay transfusion service. And therefore, if the patient has symptoms, and we know that the patient often, the majority of patients will present with headache almost, and a little bit of an increased pulse. And then we would order 3 units of packed red cells, because, and we would, and so I know that is probably also counterintuitive, you know, that there were recommendations made by the American Association of Blood Banks to say that the transfusion trigger should actually be around about 7, and you should actually not use fresh blood products necessarily as a given, but we err on the side of using the fresh products, and we transfuse because we know that we're going to see this patient again in 3 or 4 weeks. And so I think a lot of logistic type of challenges that we have also influence the decisions that we make in terms of how much of the blood products we are using. And then just to close off with, I agree with what Rita has written in the chat, you know, that I think the blood utilization committees is probably where we should actually start this process and almost harmonize what gets done across the country to collect the same data and show the benefits of introducing the change. So that's all I had to say. Thanks.
Thanks very much, Johan. I want to start with your last comment and just acknowledge Dr. Pietrelise Wessels, that's also on the call, who's done a huge job in promoting and developing patient blood management, especially in the Free State and some other regions. And I want to encourage everyone, if your hospital does not have an active blood utilization committee, every hospital where blood is transfused should have one. And I want to encourage you to speak to someone like Pietrelise, as the South African National Blood Service helps a lot in setting up these things for many units. Another person I notice here who's done huge work in this is Dr. Jaglan Naidu in KZN, who's actually won the Premier's Prize for his work on patient blood management and blood conservation. Speak to these people, they're very knowledgeable, they can help you set it up. And this great experience, you know, you've got an opportunity when you initiate something like this to also drive it and drive a message home. And then just to say to Johan, it is true, there are the exceptional patients, especially if you live in provinces with large distances where you have to give more than 1 unit of red blood cell, because you can't, you know, get the patient to and fro easily. But I think as a general rule, we try very hard to avoid it and to really limit the numbers we give. But I do understand that there are sometimes these difficult exceptional cases. It's time to close. I just want to say a huge thank you to a very brave University of Pretoria team who tackled a massive topic. And I think it was wonderful. Thank you also for making us aware of the, making everyone aware of the blood article series that was published in August. Wonderful series that I think everybody can benefit from. They also look at anemia and heart failure and in other cancer and so forth. So really worth looking at. And thanks again to everyone who diligently attends these sessions on a Monday. We hope that it's of value to you. And I think we're busy building a wonderful group and a wonderful hematology team here in South Africa. And I appreciate also that the consultants are making time to join us and to give their very valuable inputs. It's awesome. So with that, I wish you all a wonderful week, and we'll see you again, God willing, next Monday. Bye-bye.
Thank you, Vernon.
Thank you, Prof.
Bye.
And thank you,
you.
Jan
Bye-bye.
Gert, for leading the team.